Let me know once we are live.
Yes, you can start.
Okay. Okay. Very good evening, doctors. Thank you so much for connecting with us. MSN Labs always strive to contribute to improve quality of life and ultimately society's greater good through our sustained efforts in developing and manufacturing safe, innovative, and affordable pharmaceuticals for alleviation of life-threatening disease and to serve humanity. Our vision is not only to provide affordable medicines, but also to touch human life the first. We are Amazon, serving the patients better today and tomorrow. We have established over Hyderabad, USA, Myanmar. We are the only company who invented tofacitinib and was able to bring that molecule in India for the first time. And as per reports, every year 60,000 new ulcerative colitis patients are diagnosed in India, where 25 to 40% of patients are non-respondent to the conventional therapy. So I'm really thankful to Dr. Monica, Pranav, and Dr. Is my voice audible? Rohit, I think I'm facing some network issue.
No, it's clear. Please go ahead.
Okay. So I would like to say thanks to Dr. Ramesh, Monica, and Pranav to be with us. So I would be requesting Dr. Ramesh to start his presentation. Before that, I will just give a quick introduction of Dr. Ramesh. Dr. Ramesh is a renowned gastroenterologist, hepatologist, therapeutic, and endocrinologist with more than 20 plus years of experience in his specialty in various institutes. He has been a consultant gastroenterologist in Delhi since 2002 and is currently senior consultant, head of the Department of Gastroenterology at Jaipur Golden Hospital, New Delhi. He has published more than 20 publications in various national and international journals. So, welcome, Dr. Ramesh. And I would be introducing Dr. Monica Jain as well. So Dr. Monica joined Shri Balaji Action Medical Institute in 2014, where she set up Center for Liver Disease in the hospital. This is the biggest gastro and hepato hospital in West Delhi and caters to a large population of Delhi NCR and North India. Where recently in 2019, Dr. Monica initiated DNV gastroenterology program at the center, where she has trained 4 DNB fellows. So welcome, Dr. Monica. And Dr. Praveen. Dr. Praveen is presently working as consultant gastroenterology in Sri Gangaram Hospital, New Delhi from September 2011 onwards. And in 1 month advanced endoscopy he has done in Kyushu University from Japan in November 2010 and December 2010. And Dr. Praveen has also published more than 20 articles in India and internationally as well. So welcome, Dr. Praveen. I would be requesting Dr. Ramesh to present his slide and start the presentation in the management of ulcerative colitis.
Thank you and very good evening to everyone. And thank you, Lavina, for kind words for everyone. At the outset, I would like to thank MSN for organizing this webinar on such an important topic of inflammatory bowel disease. And basically today, our focus would be on the TOFA, as Lavina has already, initiated the things that what we are discussing today is a special emphasis on the role of tofacitinib in the management of IBD ulcerative colitis. Along with me, the two esteemed members which are there in the today webinar, Monica ma'am and Praveen, they are known to me since I have started gastroenterology. Monica had been at GB Pant, and we had been going along for the 20 years, 25 years, and she had guided me in all throughout my gastroenterology career. And similarly, the Praveen is also a colleague from Maulana Azad Medical College, from that is our parent institute. I mean, from and we had been together, and he stayed nearby, and our area of practice is also nearby. All three of us in northwest of Delhi. So we are really very close to each other, and I welcome both Monica ma'am and Praveen to this webinar. And it would be really, I mean, a good presentation as well as the clinical experience, because both the speakers have a very vast experience, clinical experience of dealing these all complicated cases of IBD, and they have a vast experience, institutional experience, as well as their personal experience from their clinical side. So just without wasting much time, we just start our proceedings. The first presentation is by me. Can you please start my slides?
So you can share your screen and start.
Okay. Yeah, I think my slide is absolutely clear now.
Yes.
And my voice is also very clear.
Yes, sir. Good. Thank you.
Great. So the presentation, the topic had been assigned is describe the relationship between JAK-STAT signaling pathway in the pathogenesis of ulcerative colitis, and what is the link between them, and to incorporate the evidence-based research into the clinical practice in the management of IBD, specifically for the ulcerative colitis only, because as you know, this drug has been approved in the management of ulcerative colitis. Ulcerative colitis, as you all know, is an autoimmune relapsing remitting disease, chronic disease of the large intestine. It does not involve the small intestine, where the mucosa of the colon inflamed and develops erosions and ulcers if we see endoscopically. In ulcerative colitis patients, they have a chronic inflammation of the large intestine colon, and which triggers the symptoms of ulcerative colitis, predominantly the chronic diarrhea, which may be associated with the blood, and mucus may not be associated always with the blood. And the patients have some cramping discomfort, not really abdominal pain. They may have an issue of weight loss, blood in the stools, and various extra intestinal symptoms. I'm not going into the details of the symptomatology because I will be covering more of a pathophysiology of this condition. As far as the prevalence rate of this ulcerative colitis is concerned, a study by the Sood et al. In 2010, the prevalence of ulcerative colitis is approximately 44 individuals per 1 lakh of population in the northern part of India. This study is from the Punjab, and I think that holds true for whole of the North India at least. For the day-to-day management, we have grading for the ulcerative colitis in our clinical scenario. When we call it is a mild disease, moderate disease, and severe disease, and depending on the disease severity, we institute and start our treatment guidelines. Whether we have to use steroids, which I am enumerating, and other drugs. So the mild disease is when the rectal bleeding is there and the patient has less than 4 stools per day. And that's, if we talk of pathophysiologically, that is basically characterized by the initial damage of mucosal layer of large intestine, and it is generally not associated with any cytokine storm or cytokine increased level. Similarly, the severe disease consists of when the patient is having more than 6 bowel movements per day and associated with rectal bleeding, and it is a systemic illness with the evidence of hypoalbuminemia, and this basically indicates an exaggerated cytokine state which triggers the further overstimulation of immune cells and leads to the inflammation and ulcerations in the colon. And the moderate disease is when in between 4 to 6, And this is the true love classification which holds true for the ages. I mean, this had been which we have read in the textbook and still holds true in our day-to-day management of the ulcerative colitis. It is complicated. The acute complications are predominantly toxic megacolon is there, and perforation, hemorrhages are rare complications. In the chronic setting, it can be malignancy, and it can be associated with many extra intestinal manifestations in the form of skin diseases, eye diseases like uveitis. You have seen in the joints problem. The arthropathy is very common with the ulcerative colitis, and sometimes it may be associated with the primary sclerosing cholangitis, as you have seen in your practice. In the pathophysiology of the disease, the factors which cause the ulcerative colitis. Now it has been well proven that there are certain genetic factors, gene mutations, and the chromosomal changes are associated with increased incidence of ulcerative colitis in a given individual. And over 2,000 IBD risk locus has been identified, or the genes has been identified, and the chromosomal abnormalities have been identified. Regarding this JAK-STAT issue of in the pathogenesis and in the treatment, the variants in the gene which regulate or belong to this JAK-STAT signaling pathways are associated with IBD risks. So indirectly, that also indicates that JAK-STAT pathway plays a significant role in the pathogenesis of ulcerative colitis in all the patients. Environmental factors, like recently it has been observed and it has been seen conclusively that packaged food, junk food, increased sugar intake, increased fat intake, like in the form of either monosaturated, unsaturated fatty acids or polyunsaturated fatty acids, and lack of fibers are also associated with the increasing incidence of and the prevalence of ulcerative colitis in our society. There are, of course, immunological factors, like it is associated with the other autoimmune disease also. We have seen many patients who are having evidence of other autoimmune disease, and they do have ulcerative colitis too. The other factors which are, of course, very important is the dysbiosis or the dysregulation of the bacterial flora in the intestine. And although there are various theories are there whether that is the cause or whether that is the effect of ulcerative colitis, that is still under the studies, but definitely dysbiosis plays a very important role in the pathogenesis of ulcerative colitis. Regarding the pathogenesis, under the normal physiological conditions, the homeostasis is normally exist between the commensals gut flora, the normal gut flora, which we all are aware of, and the epithelial barrier, which forms the interface between the luminal microbes and host immune system. Immune cells within the tissues are important, and they triggers the various cytokine response, increases that, and that leads to a cascade of inflammation and leads to the inflammation destruction of colonic mucosa. Here I would like to just mention the two important cells which are present in our intestinal, lamina propria and the intestinal lining are the Paneth cells and the dendritic cells. The Paneth cells, basically they have the antimicrobial properties, and they also produce the M cells. M cells also activate to produce the dendritic cells. Dendritic cells are very important because they are the main cells which leads to the presenting of various antigens which go into our colon and leads to the immunological tolerance to the antigen, because as we take lot of bacteria, lot of other things in the intestines, and our intestines are continuously exposed to those antigenic stimuli. So there the dendritic cells play a very important role in immunological tolerance via both the innate and adaptive immunity in a normal individual. So what happens in ulcerative colitis, that this homeostasis is disrupted in a genetically susceptible host by the specific environment, like dietary factors may play a contributing factor, which I have just mentioned. The antibiotic intake has played a very important role. Now it has been studied, that the patients who have been exposed to antibiotics, they are more susceptible to that, and then various enteropathogens, stress, genetic factors, they really leads to hyperactivation of the T helper cells and T17 cells specifically, and which leads to the disruption of barrier or you can say the gut, the leaky gut syndrome, and leads to increase in the tight junction intestinal permeability, and it is a features of inflammatory bowel disease in both Crohn's disease as well as in the ulcerative colitis. And this cascade leads to the uncontrolled chronic inflammation, and which leads to the endoscopic and clinical findings of ulcerative colitis. And this activation of T helper cells 117 involves the dysfunctional response from our innate as well as adaptive immune system. The innate system is which we inherit, and the adaptive is which we develop when we are exposed to various antigens, or from the antigen presenting cells in our normal course of life. The multiple inflammatory cytokines are overexpressed in that, and amplification of this immune response leads to phenotypic expression of the disease and tissue destruction, and it mediates the dysfunctional cell-to-cell interactions in innate and adaptive immune response pathway. So if you see this, that diagram, and that this cartoon explains the whole pathophysiological mechanism of ulcerative colitis in the form that the disruption of tight junctions and the mucus layer covering the epithelial cells causes increased permeability of intestinal epithelium, resulting in increased uptake of luminal antigens. Circulating T cells bearing the integrin binds to the colonic endothelial cells microvasculature and leads to the inflammatory cascade, increased entry of gut-specific T cells into the lamina propria, and that leads to the upregulation of inflammatory chemokines. And the chemokines are predominantly, as you are well aware, TNF alpha, various interleukins 6, 12, 23, and interleukin 1b, and that leads to a initiates the cycle of inflammation and inflammatory disease. So now, what is the JAK stat? There has been a significant advances has been made in defining the signaling pathway through which these cytokines, which I have mentioned, like the TNF alpha, this interleukin 6, and all these cytokines which are important in the inflammation, exert their intracellular effect. How do they exert their intracellular effect? That is basically through the JAK state pathway. JAK state, Janus kinase signal transmitter signaling pathway, transmits the information from these chemicals outside the cells, and which causes the DNA transcription and activity in the cell. And JAK state system is the major signaling alternative to the second messenger system. The JAK system consists of three main components: a receptor at the luminal aspect, JAK kinase, and the STAT protein, signal transducer and activator of transcription. And JAK, which has the tyrosine kinase activity, binds to some cell surface receptors, and that triggers the activity of various JAKs. And with increased kinetic activity, the phosphorylated tyrosine residue on the receptors, it possesses specifically STAT H2 domain, which recruited to the receptors, and then it leads to the transcription of actively made gene and going into the nucleus. So this is the how this pathway works. Again, this cartoon explains each and everything, that cytokines increases all these things. They stimulate the the JAK and proteins, and they get activated, phosphorylated. STAT proteins are produced. STAT proteins are dimerized. They are translocated to the nucleus. Gene transcription is started, and that leads to the cascade of inflammatory response, which is the characteristic of inflammatory bowel disease and our target for the treatment. The treatment goals for these conditions are the induction of remission and the maintenance of remission. The classification of ulcerative colitis drugs, as this chart enumerates all the drugs. Aminoglycosilates, as you know, the sulfasalazine, which was the old drug. The mesalazine is basically the breakaway from this. The sulfasalazine is disintegrated into 2-sulfapyridine as the mesalamine. As you are well know that sulfapyridine is basically responsible for many side effects which are associated with the sulfasalazine. Valsalazide is the basically another aminosalicylates where the 5-ASO bond ensures that the drug is delivered in the distal most colon. Various cortical steroids are available in the form of budesonide, which is a locally acting steroid. The systemic administration, we have prednisolone, dexamethasone, hydrocortisone. In the immunosuppressants, we have the azathioprine, methotrexate. Antimicrobials are also sometimes used for the treatment of ulcerative colitis. Then a biologicals group of drug consisting of infliximab and adalimumab. JAK inhibitors, which we'll be discussing, with tofacitinib. The another JAK inhibitors are the udecitinib and baricitinib. And of course, the surgery is the last resort. And in the current scenario, if your patient is not responding and deteriorating in spite of all the treatment modalities. Just the two words for the 5 aminosalicylates, and they are the mainstay of therapy only for the mild to moderate ulcerative colitis. They are not a drug of choice for the severe disease, for which you have to resort to another group of drugs. We have preparations sulfasalazine, mesalamin, as we have mentioned. They are effective in inducing and maintaining remission, both only for the mild and moderate disease, not for the severe disease. Topical mesalazine treatment is may be good enough for the left-sided disease, and it can be combined with the oral aminosalicylates for the greater efficacy. Corticosteroids are used in the acute treatment for the moderate to severe colitis for inducing the remission. They are not the drugs for sustaining or the maintaining the remissions. So the short course is steroid is required. The preparations are the oral prednisolone, methylprednisolones in the IV form, as well as oral form, and intravenous form hydrocortisone. Budesonide is a new glucocorticoid which is predominantly has a mucosal, and the local action is released entirely in the colon, has minimal or almost no systemic glucocorticoid side effects. The dose is 9 mg per day for 8 weeks, and no taper is required in this. And rectally administered steroid enemas may provide therapy for the flares in the distal ulcerative colitis up to splenic flexion. Thiopurines are the drugs which are required only for the maintenance of remission. They are not appropriate as a solo induction agents for the patients with severe disease because due to their slow onset of action. So basically, thiopurines are you induce the remission by using these steroids. But once the steroids work is finished, the patient goes into clinical remission. You start the thiopurines for the maintenance of remission. The two drugs are available, azathioprine and 6-mercaptopurines. The cyclosporin is another drug which is used for the acute severe ulcerative colitis in the doses of 2 to 4 mg per kg per day given in the continuous infusion. However, this drug is not commonly used in routine clinical practice because of nephrotoxicity, opportunistic infections, and a small risk of accelerated hypertension and seizures. Then lastly, we have nowadays biologicals for the management of acute severe ulcerative colitis for both maintenance as well as the sustaining the remission in ulcerative colitis. The preparations are infliximab, adalimumab, and other preparations which nowadays are there are the anti-integrin agent vedolizumab, which is also available nowadays, and which can be very useful in the patients who are not responding to corticosteroids. And even the American societies, they recommend using them in the first instance only when the patient is having acute severe ulcerative colitis. Thanks for your patience. Thank you for. I think we can take up the questions at the last. So I think we can straight away go for the second presentation by Praveen. Am I audible?
Yes.
Praveen, can we start? The Praveen is basically assigned the topic as his main emphasis would be on the tofacitinib and what is the role of this drug and what is the data which is available to us in the management of ulcerative colitis, and whether it is really a game changer in the management of ulcerative colitis. Over to you, Praveen.
Thank you, sir. And thank you for understanding the complex pathophysiology of ulcerative colitis.
it is very difficult to understand the pathophysiology of ulcerative colitis because number of factors are involved. It is environmental, it is genetic, and part is which is not known. So he has also told us about the number of drugs which are being used for the management of ulcerative colitis and has laid down the foundation of JAK-STAT pathway. So a little bit about the JAK-STAT pathway, which Dr. Ramesh has already enumerated. So my topic will be what are the drugs which are available for the treatment of ulcerative colitis which acts or that inhibits this JAK-STAT pathway. So we know that ulcerative colitis is a multifactorial disease with a relapsing remitting pattern and which is characterized by chronic inflammation. And this chronic inflammation is predominantly mediated by multiple cytokines which act through JAK-STAT pathway. So we, number of all the time we heard different terms in terms of JAK-STAT. Sometimes we say cytokines, sometimes we say chemokines, sometimes we say JAK, sometimes we say STAT. What does all it mean? Cytokines are a broad group in which are the agents which act on number of receptors. Chemokines are part of cytokines which normally helps in the attraction of various cells in the lamina propria. So chemokines predominantly attract neutrophils, macrophage, and cytokines. These are the agents which acts as an signal pathway which acts on the cell membrane. So these are the different terms. Then we word use JAK. Initially, JAK was just another kinase because when they were discovered, there are a number of kinase in the cytoplasm. So they were just considered as just another kinase. So JAK was term for that. But lately it was named as genus activated kinase. What is this genus? Genus is it's a Roman god which has got two faces. One is a positive phase, one is a negative phase. So based on that, the JAK term was used that because even this pathway has got some positive and some negative, one positive effect and one negative effect. So this was named as genus activated kinase. Then the STAT pathway is the signal transducer and activation of transcriptors. So why we are using both JAK and STAT combinedly? Why not separately? Because it may be possible that we have some other inhibitors which inhibit just the STAT, some inhibitors which just affect the JAK. For anything any signal which acts on the cell membrane by through some receptors, these are known as cell wall receptors. This JAK is not a receptor. It is something which is in the cytosol which is attached to the receptor. So this is a receptor and JAK is attached to this, and it has got two faces. So if there is some cytokines which Dr. Ramesh has already told, like there are a number of cytokines like interleukin 22, TNF alpha, interleukins 2, 4, 6, 9, 21, 23, the number of cytokines which have been implicated in the pathogenesis of IBD. So once these cytokines, they act on these receptors, there is a transformational change in the receptor. That is, they come close together. When they come close, that is, this is a dimerization of the receptor. It means the two receptors comes together. So there is a transformational change in the receptor which activates the JAK. It means, how does it get activated? That there is a transformational change so that the ATP becomes utilized and it becomes AMP, and one part of the JAK becomes phosphorylated. When it gets phosphorylated, it means that JAK has become activated. Once the JAK has become activated, because this cytokine cannot go directly into the nucleus, it needs some mediator. What does it mediator? The mediators are known as STAT, that is the signal transducer and transcriptors. These are the certain agents which can go into the nucleus and cause transformational changes in the DNA to produce number of other cytokines or number of other proteins. So these cytokines, because they do not go directly into the nucleus, they need some agent which is known as STAT. These are transcription agents. So they can go into the nucleus and they can cause the mediated agent. So STAT can dock only on the JAK once it gets phosphorylated. Once this gets phosphorylated, STAT can also get phosphorylated because of the phosphorus which is attached, also utilizes the ATP. And there is a dimerization of the STAT. There are two receptors of the two agents of the STAT also get united, and then they go into this nucleus to cause changes. So this is the basic about what is JAK and STAT. Now we go ahead with this. So what is the rationale of targeting JAK and STAT? Dr. Ramesh has already told that there are a number of cytokines which are implicated in IBD, and they can only cause inflammation by producing number of proteins which cause inflammation in the mucus and in the lamina propria. So JAK plays a role in regulating cellular proliferation, differentiation, and immune modulation. So JAK has just not role in just proliferation and differentiation, but it also acts on the immune mediation of the cell. JAK-STAT is a major signaling cascade downstream from the cytokine to the growth receptors. So we have 4 members of the JAK family. We just have written down 3. There are 3 JAK, that is JAK1, 2, and 3, and one other is tyrosine kinase type 2. So these are the 4 members of the JAK kinase. There are 7 families of STAT, that is, there are 7 transcription factors. All of these are important because, like if you're talking about tofacitinib inhibits JAK1 and JAK3. So it acts on JAK1 and JAK3, and similarly it acts on STAT5 to inhibit most of the things. So number of JAK inhibitors are also there in the market, which acts on specifically JAK type of receptors. So JAK serves to transduce signals to cytokine receptors. So there is a difference between transduction and transcription. When we say transduce, it means it gets activated and it activates the STAT. When STATs get activated, it causes transcription. So that goes into the nucleus. So rationale for targeting JAK-STAT signal is that the JAK inhibitors interface with JAK-STAT signaling. They compete with ATP for binding to the kinase domain. I told you that JAK only get activated when the ATP is used. So these drugs like tofacitinib, they bind to the site on JAK where ATP is utilized. So they cannot utilize the ATP and they do not get phosphorylated. So thereby they inhibit the JAK. JAK inhibitors are used effectively in another chronic inflammatory conditions like in rheumatoid arthritis, psoriasis. So this has been used for many years, and we have used this thing in ulcerative colitis based on their role. So JAK inhibition is a potential therapeutic target in ulcerative colitis because it inhibits JAK1 and JAK3, and most of the chemokines like interleukin 2, 6, 7, 9, 11, 21, 23. These are the mediators which activate JAK1 and JAK3. So if we are blocking these cytokines, we are inhibiting the inflammation in the mucosa and in the submucosal level. So these are the receptors. These are the various JAK. That is, we have JAK1, JAK3, JAK2, another tyrosine kinase 2. These are the 4 types of JAK families. Then we have 7 subfamilies of STAT from STAT1 to STAT7. Once these get activated, there is a docking of STAT on the JAK. This causes dimerization of 2 molecules of STAT. That is, these 2 molecules come together. This is known as dimerization of STAT. Then here they goes into the nucleus and cause transcriptional changes. So these interferon, interleukin 10, they do not act directly to the nucleus. They act through JAK-STAT pathway. So if we have biological therapies, which we have number of, which blocks the interleukin 6, which block TNF alpha. But suppose they are not active, they are not able to negotiate those inflammation. So these are the pathways which are down into the cell, and these are the drugs which acts on these pathways to downgrade the inflammation. So initial potential therapies were on this level. Now the potential therapies are on the signaling level. So there is a change in the management of ulcerative colitis. So what are the treatment goals in patient of ulcerative colitis is to induce remission and maintaining it. This is our goal. These are the different classification of drugs which Dr. Ramesh has already told. So I'm not going into the details. So we are just focusing on the JAK inhibitors. JAK inhibitors are not biological therapies. They are known as targeted inhibitors because we know they are acting on particular target, that is, they are inhibitors of signaling pathways. So tofacitinib is currently being used and it is FDA approved. So we are using it for ulcerative colitis. So current treatment management of ulcerative colitis is most of us, they use aminosalicylates for the mild. If the patient is not controlled, we are using either steroids or maybe add-on azathioprine. And sometimes we are using, if the patient is severe, we give steroids, maybe biological therapy, cyclosporine. Sometimes patient is allergic, then we give tacrolimus. So these are the management protocols of ulcerative colitis. But still, we all know that despite we are using all sort of therapies which we have, about 25 or maybe up to 40% of these patients, they do not respond to all sort of combination of therapy. So we need more drugs for the management of ulcerative colitis. So thereby we have JAK kinase inhibitors. So tofacitinib, which is being FDA approved, is a Janus kinase inhibitor, that is JAK. Initially, it was just another kinase. So it is JAK inhibitor. It binds to the JAK enzyme and thus downregulates the production of pro-inflammatory cytokines. It is approved by both by the European Society and the US Society. It is used both as well as for the induction as well as the maintenance. The first landmark study was published in NEJM in 2017, and which is known by the name of Octave 1, Octave 2, and the Octave 3 also. And based on that, it is being approved for the management of ulcerative colitis in 2018. So tofacitinib, the mode of action is it binds to the JAK enzyme and thus downregulates the pro-inflammatory cytokines and thereby reduces inflammation. So the major study which was published in NEJM was the phase 3 randomized double-blind placebo-controlled trial of tofacitinib in adult patient, that is from age 18 onwards. So role of it in less than 18 is not still approved by the FDA. So if you have some patient who is young, then tofacitinib should not be used. Number of patients which were enrolled was about 1,139. In Octave 1 induction, 598 patients were enrolled. In Octave 2, 541. The protocol was same in both the groups, and it was in different countries. So patients were randomly assigned to 4:1 ratio. Who are those patients? These are the patients who have not shown any remission. Even if they are using, these patients have been exposed to steroids, or they have been exposed to azathioprine, or they have been exposed to biological therapies. If these patients are not responding to all those therapies, these are the patients who are enrolled. So once these patients are enrolled, then azathioprine and this biological therapies were stopped. ASA, steroids, and tofacitinib was given, and in one group, and placebo was given in another group. And the Octave 1 and 2, the endpoints were remission at 8 weeks. So based on this large RCT, which has shown that remission at 8 weeks was 18% in patient taking 10 milligram of tofacitinib twice daily. If you see just 18% of remission, it looks very like minimal. So if the patient has not responded to steroids, to biological therapies, and these patients just respond 18%, but there are still 18% who are responding. And if you compare to placebo, there are only 6. If you go by the data, the remission is at 8 weeks is just 18%. It is not just something which is very, very landmark to say that it is creating such a that it is causing remission in everybody. So the remission is seen in only 18%. But what is the definition of remission, which is important? The definition of remission in this study, as in most of the studies, is that the activity of the ulcerative colitis was taken based on Mayo score. Mayo score is a standard which is being used in all the studies, and it's based on 4 criteria. One is based on the number of stools, second is the bleeding, third is the endoscopic, and fourth is the global assessment as by the physician. So there are 4 components, and each component is given 0 to 3. So you have points from 0 to 12. So when we say severe, normally it is more than 6. And according to remission in this criteria, if the Mayo score is less than 2 points, suppose the patient has a Mayo score of 6, and then it has come down to 4, then it is considered as remission. But the important point is that in that remission, the rectal score, which is from 0 to 3, should be 0. That is, there should be absolute no bleeding at all. So based on that criteria, the remission rate is about 18%. If we give tofacitinib 10 milligram twice daily for 8 weeks. And if we see clinical response at 8 weeks, and what is the difference between remission and clinical response? When we say clinical response, which is about 58%. So there is a huge difference between 18% and 58%. So there should be some difference between the remission and clinical. When we say clinical response and 8 weeks, it means that the Mayo score has reduced to less than 2, but the rectal score, that is the bleeding, can be there. That it is not absolute 0. It may be slight improvement in the bleeding. When we say there is a slight improvement in the bleeding, means the rectal score out of 3 can be 0 or 1. It is not 0 as in remission. If the patient even after 8 weeks has slight bleeding, but the score has reduced to less than 1, the maximum is 3, and if it is reduced to 2 or maybe 1, and this is considered under clinical response, the response is 58%. So this terminology has to be, one should be aware of that to say that the tofacitinib is whether a wonder drug or it is just another part and parcel of other drugs. So clinical response, which has been said to be about 58%, is because the patient has less than, the Mayo score has reduced to less, the basic from the baseline to less than 2, but the bleeding is not 0. That is, there is no absolute decrease or no bleeding per rectum. When we say remission, it is 18% when we say there is absolute zero in the bleeding. So the mucosal healing is also about, you say about tofasutinib is about 33% or 31%, both in the octave 1 and octave 2. And in the maintenance patient who have achieved, that is the remission, they were, those are the patient, that is about 20% who achieved remission. They were enrolled in maintenance therapy, where 5 milligram BD was given, and these patients were followed up for almost a year. And if these patients were followed up for a year, out of those, that is about the 20% who have achieved remission, only 34% they keep on maintaining the maintenance on the same date, about 34%. So out of 20, 34% they continue to have the same level at about 1 year. So this is how tofasutinib is acting at present in the real world scenario. So efficacy data, this study, which is a large based study published in NEJM, has shown that it has been able to achieve remission in those who have not been achieved remission by number of other drugs in about 20%. And out of those 20%, if you keep on giving the drug to the lesser dose, that is 5 milligram twice daily for 1 year, about 33% of these patients, they keep on maintaining the maintenance about a year. So the effect of tofasutinib appears to be rapid. That is the only thing. It has shown to reduce the stool frequency and rectal bleeding as early as day 3 in this octave study. So patient has got, if the patient is responding, the patient will respond as early as 3 to 5 days of initiating the therapy. Just to conclude, the introduction of tofasutinib in the treatment of UC adds to a new therapeutic strategy and increases the possibility of curing UC patient. In the absence of head-to-head clinical trials demonstrating a clear superiority of one drug versus other, treatment of choice would depend upon the patient preference and characteristics, because tofasutinib has not been compared to steroids alone. It has not been compared to salicylates. It has not been compared to azathioprine. So it is just an add-on drug to those patients who have not responded to combination of these three. So I don't think we should start tofasutinib right from the beginning to the patient who has just come to us, because it is presently being used in those patients who has not been, who has not responded to the previous therapies. So what about the side effects and the precautions? One should monitor the skin lesions, because herpes zoster has been shown in this octave study. Skin malignancy has also slightly increased, but not statistically significant. Tuberculosis flare has not been documented in the octave, but I have my doubts that probably tuberculosis has to be taken into consideration by starting on JAK inhibitors, because JAK inhibitors in patients who have been used in psoriasis or rheumatoid arthritis has shown that tuberculosis rates are slightly on the higher side. Cholesterol, especially LDL, has increased. Risk of pulmonary embolism is still there. Associated medications like azathioprine, TNF blockers interactions are not known because they have been excluded from the octave trial. Induction is about 20%, and maintenance of those patients with induction is about 30 to 35%. Thank you.
Thank you,
Hello?
Dr. Praveen, for an excellent presentation. You have cleared, presented really the very robust clinical data, the various studies on the uses of tofasutinib in the management of ulcerative colitis. And the only point which I want to slightly add or this thing is that if the clinical remission, because in the NICE guidelines, if your clinical and this remission is not there in that 8 weeks, we can extend the 10 milligram BD for the 16 weeks or so. So that's the, and we will discuss these points later on. And I think we just finish off the presentation by Monica ma'am. So I invite Dr. Monica Jain for the case presentation for ulcerative colitis. Thank you.
My slides are visible?
Yes.
Slides are visible?
Yes, ma'am. Yes.
And voice is also okay.
Yes, ma'am.
So after listening to pathogenesis and the status of tofasutinib in management of ulcerative colitis, I will present.
I'm sorry to interrupt. Slides are not in full screen.
Okay. Just
Yes. Yes, ma'am.
फुल स्क्रीन नहीं है, फुल स्क्रीन करो उसको। Now they are okay?
Yes, ma'am. Yes, ma'am.
So I will be presenting a case of use of Tofa in steroid refractory ulcerative colitis. This is the actual case which we had in our department 3 months ago. The patient was a sister to a doctor who was a 70-year-old female who was diagnosed recently to have steroid refractory ulcerative colitis. She was a known case of UC, taking treatment for last more than 3 years, but now she was refractory to steroids. There was no other comorbidity except for she was a case of seizure disorder. She was already on anti-epileptics. She presented to us with pain abdomen, increased frequency of blood mixed with stool, generalized weakness and joint pains. On examination, the vitals were okay and she had diffuse abdominal tenderness. She was worked up. Her hemoglobin was low. CRP was high, and her stool was sent for bacterial and parasitic infection, which was negative. The stool was sent for C. difficile and glutamate dehydrogenase, that was also negative. A CT scan was done in view of she had persistent tenderness in abdomen. So that showed thickening of bowel wall from transverse colon to rectum. There was pericolonic fat stranding, and a colonoscopy was done which showed severe ulcerative colitis, Mayo grade 3, involving transverse colon, descending sigmoid and rectum. A colonic biopsy was done, and the biopsy was sent for CMV along with RT-PCR for CMV. Initial management started with IV fluid correction, electrolyte correction, antibiotics, analgesics were given. Patient was continued on anti-epileptics as she was already taken, and IV steroids were started. Biopsy report was suggestive of CMV. Intravenous gas cyclovir was started in the dose of 5 mg per kg for initial 5 days, followed by oral drugs. Subsequently, the biopsy after 2 weeks, RT-PCR was negative and therapy for CMV was discontinued. In spite of this treatment for CMV, the patient continued with symptoms in which she had persistent bleeding PR and pain abdomen. After completing CMV treatment, a repeat colonoscopy was done, which showed persistent Mayo grade 3 changes. At this time, we decided to escalate the treatment. The option for surgery versus biologicals was discussed with the patient, but patient and their relatives, they were reluctant to both of them. So considering refractory UC, it was decided to start with Tofa, and it was started at a dose of 10 mg twice a day. Patient symptoms, they started improving within 3-4 days, and she started improving. Her stool frequency reduced. There was bleeding PR also reduced, and after 8 weeks, a colonoscopy was done, which showed healing of lesions, and endoscopic Mayo grade 1 changes were there. The dose of Tofa was reduced to 5 mg twice a day after that, and she has been continuing this therapy till today. So the pre-Tofa workup, which is recommended, is basically a complete history and examination, a complete history of the associated conditions like cardiovascular diseases, history of venous thromboembolism. In this particular patient, she had edema feet, extensive edema feet. We got a Doppler study to rule out thrombotic tendencies, the lung disease, and if the patient is having history of diverticula associated, then they should be watched for acute abdomen, history of herpes zoster. Pregnancy is not indication for this Tofa. Complete blood counts, serum creatinine, LFT, lipid profile, all these should be worked up prior to starting Tofa. As far as the serology is concerned, hepatitis B, C, and HIV, they should be ruled out. A Montu test and IGRA should be done to rule out this latent tuberculosis, as Dr. Praveen has already mentioned. All the data, major data in Tofa we have is from the studies in rheumatoid arthritis and in psoriatic arthritis and skin conditions. There, the reactivation of tuberculosis was seen. But in our Octave trial, this has not been mentioned clearly that was there any case who had reactivation of tuberculosis. So where not to start Tofa is if the person has hypersensitivity, pregnant lady, breastfeeding lady, if absolute lymphocyte count is less than 500, absolute neutrophil count is less than 1000, or hemoglobin is less than 9, patient is positive for hepatitis B, C, and HIV, active tuberculosis, serious localized or opportunistic infection. This is very important to understand because many of these patients, they are already on steroid because of active disease, and they develop fungal infections also. One of our patients already admitted with us, she is a candidate for Tofa otherwise, but she has severe fungal candidiasis, esophageal candidiasis. So we are treating that patient for candidiasis before we can start with Tofa. Screening for latent tuberculosis has been addressed in ECO guidelines for in respect to biologicals, in which they have advised chest X-ray, tuberculin sensitivity test, IGRA test that should be done in patients who are started on biologicals. And if the patient is found to be latent tuberculosis, then the treatment should be delayed for at least 3 weeks. They should be started with anti-tubercular therapy before starting therapy for as biologicals. And if patient is having active tuberculosis, then anti-TNF should be delayed at least for 3 months. So this is a very important thing because in our country, tuberculosis is very common. And if active tuberculosis was diagnosed on patients who are already on anti-TNF therapy, then ATT should be stopped and resumed after 2 months of anti-tubercular treatment. So TNF should be stopped and resumed after 2 months of anti-tubercular treatment. So I think we probably will have guidelines in Tofa also because the mechanism almost takes care because this is basically Tofa acts through all the signaling pathway, which is the final pathway. Even when we study mechanism of action of biologicals also, the final pathway acts through JAK-STAT pathway. So probably we will have guidelines for this also. As far as herpes zoster is concerned, the incidence of herpes zoster reactivation was there in 5% of patients on 10 milligram dose, and it was 1.5% in 5 milligram. That means the dose, if we reduce the dose, the incidence of reactivation of herpes zoster is reduced. So it was said that 85% of patients with antiviral therapy, these infections, if a person develops herpes zoster, almost all of them, they resolve with antiviral therapy and none of them, they had a death. So infection is there, but that can be treated with antivirals, either acyclovir or famciclovir, and this should be given at least for 7 to 10 days. Tofa need not to be discontinued. This is very important. If a person develops herpes zoster on therapy, Tofa need not to be discontinued during therapy for herpes zoster. If we are suspecting that this particular patient is going to be a candidate for Tofa, vaccination should be done to prevent herpes zoster. We have 2 types of vaccine, live vaccine as well as non-live recombinant vaccine. And in this case, recombinant vaccine is recommended, and vaccine at least should be given for 4 weeks prior to start of Tofa or biologicals. This I have already mentioned. What are the absolute counts we should keep? ALC absolute lymphocyte count should be maintained more than 750 when we are monitoring these patients. If this is less than 500, we discontinue. If the value is between 500 to 750, try to reduce the dose of Tofa. Absolute neutrophil count, if they are more than 1000, maintain it. If less than 500, discontinue. In between, reduce the dose. The similar lines are there for hemoglobin. If less than 2 gram percent hemoglobin drop is there, maintain it. And if this is more, then we can reduce the dose. Many of these patients are on some other drugs also, because the mechanism of action of these TOFA is through activation of other CYP enzymes. So the co-administration of ketoconazole, fluconazole, rifampicin, methotrexate, tacrolimus, and cyclosporine, the pharmacokinetics needs to be modified. The dose needs to be modified because they all interfere with the metabolism of these drugs. Lastly, coming to if the patient is having some hepatic impairment, if Child-Pugh A is there, no dose adjustment is required. If the patient is having Child-Pugh B, then dose should be reduced. And if it is Child C, then patient should not get TOFA. As far as renal impairment is concerned, mild, if the clearance is 50 to 80, no dose adjustment is required. If this is 30 to 50, no dose adjustment is required. But definitely, if the creatinine clearance is less than 30, then definitely patient should discontinue with the drug. There are 2-3 more scenario which is there. If a patient had a episode of thromboembolic phenomena in past and patient is reluctant to take this particular drug, then there are case reports in which the patient can be co-administered with low dose heparin along with TOFA. Another scenario, if the patient develops increase in cholesterol or increase in LDL, then in that case, patient needs treatment. As far as the prophylactic treatment of hypercholesteremia or hyperlipidemia is concerned, that should not be done. It should be monitored, and if patient develops, then only we should start with the therapy for hyperlipidemias. Thank you.
Thank you, Monica ma'am, for an excellent case presentation of this uncommon CMV superinfection with ulcerative colitis and enlightening us with the clinical details of TOFA, what are the interactions, and going into the details, what are the indications, what precautions you have to take. I think you have covered all the clinical relevant aspect of tofacitinib to be used in the practice. So this is great presentation from your side. So, I think we have covered almost all the aspect from the pathogenesis with the special emphasis on this JAK state pathway. I mean, with the mechanism of action of this tofacitinib and the clinical efficacy of this drug, which has been very well outlined by Praveen. And you have presented the data regarding the uses, the precautions which we have to take before starting of this drug, which is a very, I think, value-added drug in the day-to-day management of ulcerative colitis. So, do we have any questions from? Do we have the other participants or questions from any other audience? Yeah, the organizers, can you people?
Yeah, hello.
Yeah. Do we have any questions from any other participants?
Yeah, we have received few questions, sir.
Yeah.
Okay. So first question is, how do you rate tofacitinib versus biologicals?
I think this question Praveen can answer. Yeah.
There are two ways of comparing this. There is no study which has compared tofacitinib with biological therapy. But in India, if you consider as the cost as a factor, maybe then tofacitinib is probably preferred. Tofacitinib is an oral drug compared to most of the biologicals, which are all injectables drug. And second is about the efficacy. That is an important thing, because sometimes the efficacy is most important, because we do not have a head-to-head comparison and use of tofacitinib, especially in those for induction and for maintaining in naive patient. So we cannot compare these unless and until we have some comparison, then we are able to answer that, because it is very difficult to use tofacitinib right from the beginning. If the patient is, if you want to avoid steroids, if you want to avoid some biologicals, and using 5-ASA along with TOFA right from the beginning is not approved by any society. So unless and until we have more guidelines, we have more comparison, this answer is difficult to answer.
Dr. Praveen, I mean, just an extension of this question, can you have just some, any subgroup of patients where you would prefer the biologicals, as compared to this TOFA, and starting with, I mean, can you just considering any specific indication?
Because the Octave trial is the Octave, which is the only trial which based on which it is FDA approved. It has used Tofastotinib in patient who is refractory to treatment for biologicals, for azathioprine, that is for the purine inhibitors, and for ASA. So these are the group. But in practice, I think if the patient is steroid dependent also, and I have used it, but if the patient is steroid dependent and if you are using Tofastotinib, then it has shown some benefit. So these are the only other subgroup in which we can use that. If the patient is steroid dependent and is in remission or is responding to that.
In children also, because we don't have data in children.
Yes, in children we can.
Non-responding children, or you can say Crohn's disease, where we need to modify the treatment. In those cases, TOFA does not work in Crohn's.
Yes.
So,
The only subgroup which probably is just based on the experience is probably steroid dependent UC.
Yeah,
And
we can take another question.
yeah, next question which we have received, sir, is can Tofastotinib 10 mg can be used along with Mesalamin?
Yeah, that can be very well used. I mean, the trials also, I mean, we have continued with the 5-ASA drugs with the, so it is of course an integral part of the management. It has to be continued, of course. Regarding the usage of 5-ASA also, I mean, as the guidelines are also there, and in the trials, in the few studies, like the patients who are not very well responding to the low dose, I mean 2.5 grams, and the dose can be escalated to the 4.8 gram of Mesalamin, and you would have high rates of induction of remission in these patients. So these are the another thing which we would like to add here. Yeah. Any other comments from the other two esteemed speakers?
Yes, I agree with you that it normally it is used along with the 5-ASA. 5-ASA never been stopped.
Because none of
Next
the trial
question.
has compared this with TOFA without 5-ASA.
Right. And the last question is safety profile of Tofastotinib. Like, what's your comment on safety of Tofastotinib?
See, we have data for 9 years in the rheumatoid arthritis patients, which has been, published data. And it is a relatively safe drug. So all the side effects which has been there listed, probably they do not have much clinical significance. Even in the Octave trial, the clinically significant, the side effects as compared to the placebo were not seen. There was no higher incidence of tuberculosis or any other. Even the herpes was, demonstrated in that Octave 1, 2, 3 trials. And for the rheumatoid arthritis, I have gone through that, and no clinical significant side effect profile has been seen. And of course, in the another word of caution which I would have here is that the elderly patients, specifically like post-PTCA patients, or the patients who are already having the pre-existing cardiovascular disease or the CVA, there you have to be a bit cautious. I mean, probably, not to use all these type of drugs. But otherwise, I think as far as infections and all the things are concerned, this seems to be slightly, exaggerated this thing, and in the clinical practice we don't see. I've spoken to my this immunologist colleague also. I mean, the Praveen is having the another comment, and ma'am also, that our immunological colleagues are using this drug, the left and right. I mean, in many patients, and they also share their experience that they do not see a significant amount of opportunistic infections, tuberculosis, herpes, and all with this drug. So as far as side effect profile is concerned, seems to be a pretty okay drug. I would invite the comments from the other two speakers too. Yeah.
In Octave trial, the clinically significant side effects which were seen were just a nasopharyngitis and some increased incidence of this herpes zoster. And that was also mild to moderate, that could be managed with drugs. None of them led to mortality. So probably the safety profile is very good. I think rheumatologists are using too many patients of they are on Tofa. They write in almost every third patient is on Tofa.
And ma'am, just one thing to add, because even if probably the fourth wave will come of the COVID probably in June, and even if the patient is on Tofa and the patient becomes a COVID patient, even the Tofa has shown some efficacy in the COVID. So we
Yes,
can
yes, definitely.
So
COVID,
you are
there's
you
no
are pushing the
contraindication.
baricitinib out of that.
no.
So Nika, so that would be after you, man. Yes, yes, okay. Good point. That is a
Okay.
very well taken point.
Because it may be possible that probably we are coming up with the COVID patients. So whether to stop tofacitinib in those patients is an issue, but I think it is considered as
Tofa
safe.
need not to be stopped. Yes, definitely.
It is considered to be safe.
Yeah. A great discussion, doctors. So that was the last question which we received from the audience. So thanks to all delegates for joining today and giving your time in creating all this knowledge base for ulcerative colitis and its treatment, because that's the need of an hour right now. But thank you so much for giving your valuable time and to enlightening our group, our audience about the treatment. So great discussion happened today. Thank you so much to all doctors.
Thank you and a very good evening to
Thank you, ma'am.
all.
Thank you.
Praveen, enjoy yourself, and Monica, ma'am.
Thank you, sir.
Thank you, Lavina.
Thank you.